Hello everyone, welcome to our Asian Novel Seminar, which was hosted by the Arthroplasty Society in Asia. This program is focused on the arthroplasty cutting-edge technique. This is our sixth session of this program. In the former program, we discussed about the various valgus deformity and other deformity in TKA procedures. Today, we're going to focus on kinematic alignment, TKA, whether it's the way to Fogortten knee in AI times. It is our honor we have invited three famous guests, famous experts in this field. The first one is Professor Stephen Miller Howell. As we all know, he's the pioneer in TKA technique. He's the professor in University of California, Davis. The second expert is Professor Wang Yu from Shanghai Renji Hospital, Jiaoteng University. And the third one is Professor Yan Chonghoi from University of Hong Kong. And I am Dr. Chen Wenwei from Peking Union Medical College Hospital. So, as we all know this famous literature, although in good hands, there are still about 20% dissatisfaction after TKA in our patients. And another famous literature from Mayo Clinic, we noticed whether the mechanical alignment was, whether we are a mechanical axis goal within within 3 degrees is of little practical value for predicting the durability for modern TKA implants. So that's the reason we raised today's topic, kinematic aligned TKA. So let's invite Professor Wang Yu to introduce the history about mechanical alignment and kinematic alignment. Let's welcome Professor Wang Yu.
It's very nice time, and finally we can see together, in this special time. Well, I personally very lovely to join this course discussion about the kinematic alignment in TKA. But here, I will firstly talk something about the TKA with the mechanical alignment technique. Does it really matter? It is a way that do have something wrong. And actually, I will mostly focus on the potential effect of it on the knee kinematics. The conventional implantation of the TKA aims to create a neutral lower limit. You may all know that by cutting the distal femur and proximal tibia perpendicular to the femoral and tibia mechanical axis, these provide reliable long-term fixation and functional improvement. Our previous study showed that the normal Chinese mechanical alignment parameters is like this. The HKA angle is nearly neutral. The medial mechanical distal femur angle here in the slide is the IF angle is around 94 degrees, and medial mechanical proximal tibial angle here is the beta angle is around 87, and the transepicondyle axis angle is 3 degrees. So 3-degree deviation from the joint line perpendicular to the mechanical axis were found as usual. Well, TKA with kinematic alignment a different way. They try to restore the three functional axes, and that may determine the normal knee kinematic based on understanding of predictor pattern of the cartilage wear, and aims to restore the arthritis states of the patient knee. That's improving the post-operative satisfaction, and Professor Howell may detail that in a later lecture. Well, this is three functional kinematic alignment. One is the transverse axis for the femoral, and the femoral for the tibia to flexion and extend. One is the transverse axis of femur for the tibia to flexion and extend, and another one is the longitudinal axis in the tibia, about which the tibia rotated around on the femur. In early time, that Dr. Lee and Professor Howell already reported that the TKA tends to have similar or better clinical outcome, including a post-operative range of motion and KSS score and Walmart score compared to the MA TKA. It seems to restore the good knee function without catastrophic failure. And Dr. Nagro and Hozak also report that KA or MA TKA result in a comparable overall limb alignment. Following KA TKA, the femur is cut in slight valgus and the tibia is cut in slight varus, which I think is being close to the patient's natural anatomy. Well, what is the features are the low back and medial pivot. Well, and where is the knee motion axis? This may not easy to explain. The current consensus on this. So, the question is where is the knee motion axis? It's not easy to explain. The current consensus about it has been changed from the formal 4-bar link theory to now a single flexion extension axis theory. And this single extension is approximated by the originals of the collected ligament. Due to the 3 or 4 degree deviation from the natural knee surface from the cutting line perpendicular to the mechanical axis, MATKA surely changed the patient's natural knee kinematics, femur and tibia prosthetic bearing surface. And also, the MATKA changes the patellar knee kinematics by 3-degree external rotation and of the natural motion axis of the patient tracking, patellar tracking. These dimensional slides, even it only slight changes of the prosthetic joint surface from the natural surface. Well, anyhow, I think that as mentioned, the dimensional slight change and of the prosthetic joint surface from the natural knee may cause the increase of the trochlear radius at various points of bearing surface after TKA with MA technique. Such kind of overstuff could lead to surrounding soft tissue irritation and clinically patients unsatisfactory when knee is highly bended. In the past, we measured the natural knee trochlear groove anatomy and compare it to the prosthetic trochlear morphologies of the traditional mechanical alignment technique. The discrepancies of the axis location and prosthetic trochlear grooves were very great. The large radius of female component trochlears and more posterior and proximal location of its axis were found. And the relation between the anatomy of the trochlear groove and its mechanical alignment in natural knee showed that it locates slightly lateral to the mechanical alignment, but it's very slight, just within 2 millimeters in distance. And the measurement showed that in various brand of components for prosthetic trochlear grooves, the located is more lighted. The location, is move more lateral to the mechanical alignment after TKA with the traditional technique. And this remarkable lateral distal overhang after MATKA cannot be reduced by the technical modification of such as 3-degree or 6-degree flexion implantation of the femoral component. Still, you can see quite a lot overhang in a certain special place. So, the natural knee kinematic axis is complicated or very complicated. The better way to avoid them is to mimic natural knee curvature by anatomically implantation of the prosthesis during the TKA. So I think in conclusion, I should say theoretically, it does matter regarding to the knee kinematics when performing the TKA with the mechanical alignment technique that we use quite a long time. We need to change, but it's not easy. Okay, thank you for your attention. That's my talks.
Okay, thank you, Professor Wang. He introduced the history about mechanical alignment and kinematic alignment. Right now, let's welcome our special guests, the Professor Dr. Howell from University of California, Davis. He's one of the pioneers in kinematic alignment, TKA. He is going to talk about the surgical technique and indication about this technique. Let's welcome Professor Howell.
Hello, everybody, and I just want to let you know how much of a thrill this is for me to see a concept called Caliper kinematic alignment that I've been involved with since its inception in 2006 to be of interest to all of you in Asia. And having this opportunity to speak to you gives me great pride. And I think to be with such a distinguished group of other surgeons with expertise in this area and in primary total knee arthroplasty will just give us a great educational session to explore this. And what's the main goal here is that set the standard for 2021, but recognize that we need everybody around the world to look at this, evaluate it, and shape it and move it forward so that in 2022 and 2030 and so forth, our knee replacements get better and better. So let me once again thank you for inviting me. I would very much like to thank the Asian Arthroplasty Association for inviting me to speak about calipered kinematic alignment, and it's indeed an honor to be on the same panel with 3 other distinguished speakers and highly skilled arthroplasty knee surgeons. The title of my presentation is Calipered Kinematically Aligned Total Knee Arthroplasty, performed with verification checks, restores the forgotten joint score better than mechanically aligned total knee arthroplasty. My talking points, I first want to define what calipered kinematic alignment is. I then will discuss the caliper measurements of the bone resections and a series of verification checks that we record intraoperatively set the femoral component coincident with the patient's prearthritic joint lines within a 0.5 millimeter. I'll then show that these same steps can be used to set the tibial component coincident with the patient's prearthritic joint lines within a 0.5 millimeter. And finally, we'll look at a couple of studies that discuss the forgotten joint score after kinematic alignment. And I believe you'll find enough evidence there that it's better than mechanically aligned TKA and very much like a total hip replacement. Let's look at the definition of calipered kinematic alignment. Now, this schematic of an AP view of the distal femur shows the 3 kinematic axes, which we'll discuss in a moment, but it emphasizes the use of the caliper to measure the amount of bone that we remove from the femur and tibia and to adjust the thickness of the resections so that they match that of the implant, which we'll talk about in a moment. And these resections, whether they're the distal ones or the posterior ones, should be within a 0.5 millimeter of the target. So the definition is simple and clear. When we perform calipered kinematic alignment, we restore the patient's prearthritic joint lines and co-align the axes in the components with the 3 kinematic axes in the knee without the release of a healthy ligament, including the posterior cruciate ligament. Now, these are 4 poses, as you can see, of the knee, and the green line is a line centered in the radii or a best fit sphere in the medial and lateral femoral condyles, and that line is the axis about which the tibia flexes and extends on the femur. The second axis, the magenta one, is a little bit anterior and proximal to the first one, and that axis is the one about which the patella flexes and extends on the femur, and it is parallel to the first one. And the third axis is a longitudinal one that passes through the center of the medial tibial compartment, medial lateral, and just slightly posterior to the midpoint. And all 3 of these axes are either parallel or perpendicular to the patient's prearthritic joint lines. So, if we want to restore the resting lengths of the ligaments and promote harmonious patella and tibial motion on the femur without kinematic conflict and overtensioning of the knee, then we need to resurface the knee by placing the implants on the prearthritic joint surface to co-align the axes and restore the resting ligament lengths. And this then allows the knee to function if you have a medial ball and socket design, like the medial ball and socket of the normal knee, defined by Freeman and Pinskarova in their landmark work in 2005. Now let's look at the first step, because I was asked to talk about how to do the surgery. So we're going to begin with the femur, because calipered kinematic alignment is best performed when you restore the normal joints lines of the femur first, and then balance the tibia to the femur. So the target for the distal and posterior femoral resections is determining by measuring the thickness of the condyles of the femoral component that you use. As an example, I've selected this GMK sphere, which has a thickness that is distally 9 millimeters and posterior 8 millimeters. So when we cut the bone and we measure the piece and we add back 1 millimeter for the thickness of the saw blade, and when cartilage is missing, 2 millimeters for that, the combined thicknesses should be 9 millimeters for the medial and lateral distal resection and 8 millimeters for the medial and lateral posterior resections. And we strive to make those bone resections within plus or minus a 0.5 millimeter of target. The first surgical step, and we'll show the exposure of a right knee using a mid-vastix exposure, and you can see the osteotome was placed on the medial femoral condyle, and we are going to begin by removing our medial osteophytes, the osteophytes in the intercondylar notch, and the lateral osteophytes as well. We'll just show the removal of the medial osteophytes here. When there's cartilage missing, as there is in this varus knee, there may still be some on the distal femoral surface. So the easiest thing is just remove whatever remaining cartilage is present, and then add back in 2 millimeters on your distal referencing guide to correct for the loss. So we take a ring curette and remove the cartilage down to bone. Now we have to set a drill hole for a positioning rod to hold our distal referencing guide, and we want to insert it in such a way that we limit flexion of the femoral component to reduce the risk of patellofemoral instability, which is very rare in kinematically aligned total knee arthroplasty. In our experience, an incidence of 0.3%. So 3 out of 1,000 knees might have patella instability, and it's usually caused by flexing the femoral component. So to reduce the risk, we use a schematic here to show the anterior and posterior surfaces of the distal femur, and that the position to start the drill hole is midway between that location as shown by the orange rectangle. And so when it's done right, there should be, depending on the size of the femur, a 5 to 10 millimeter bone bridge between the posterior aspect of the hole and the anterior aspect of the notch. So it's important to remove your osteophytes from the intercondylar notch before you make this measurement. So here we are in the operating room again, and we have found the center of the distal femur, and we're starting our drill hole perpendicular to the distal end, minimizing flexion and entering about 10 centimeters. In this moderately sized knee, you can see our bone bridge is 7 millimeters. Now we'll select the positioning rod, which just goes into the metaphysis of the distal femur to avoid the risk of fat emboli, and we insert it close to perpendicular to the distal joint line. And then we select a distal referencing guide that says unworn on the lateral side, worn on the medial side, with this 2 millimeter buildup on the worn side to compensate for the cartilage loss. We then can translate and rotate and settle this coincident to the distal femur and pin it securely. Now that the guide is in place, we can, through the distal saw slot, create our distal resections. Remember, our target distal medial is 6 millimeters, and our target distal lateral is 8 millimeters, after we add in the millimeter of the thickness of the saw blade and 2 millimeters for cartilage. The combined thicknesses will be 9 millimeters and match those of the femoral component. So as we make our first cut, you can make a measurement, and it should be 6. Here we're about a 0.5 millimeter shy of our target. The distal lateral cut should be 8, and here it's 8 millimeters and right on target. So what can happen is your saw blade can skive sometimes. So we'll put the saw blade back in, and then you can see that we get about half the saw width removal of additional bone, which is about a 0.5 millimeter, because the saw is 1 millimeter thick. And this is much more accurate than robotic or navigation or PSI, because we have a target that we can hit within a 0.5 millimeter. Now, in order to assist the surgeon in the thought process and the flow, we recommend following a verification checks that are done in a correct series and record them as you perform the operation. So this is a record of the verification checks for Caliper kinematically aligned TKA, and in this case it's for the Medacta GMK sphere, because the thicknesses of the components are part of this verification sheet. So we can expand, as you see here, the section that is related to the distal femoral resection. And it states the target thickness, 8 millimeter for the unworn distal femur, 6 millimeters for the worn surface when there is no cartilage. If you remember, our medial condyle was worn. We resected 5.5 millimeters. We recut 0.5, and we hit our target of 6 millimeters. If you recall, the lateral condyle on a varus knee was unworn. The initial thickness of the resection was 8. We did not need to do any additional recuts, and so our final thickness was 8. And so we now know that we have restored the proximal distal and varus valgus and flexion extension position and orientations of the femoral component within a 0.5 millimeter of the patient's pre-arthritic joint line. Very, very accurate. Now that the distal resection is completed, we need to now set the 4-in-1 cutting block to make our posterior resections correctly. So we select our posterior referencing guide and set it at 0 degrees rotation. We make sure that the posterior feet are coincident with the posterior cartilage at 90 degrees. We drill our holes and we insert our 4-in-1 block for the proper femoral component size, as you see here. Now, we're going to resect the posterior bone first before the chamfers and the anterior cut. And we'll make the measurement. And if we're not quite right, we have the ability to adjust the AP and IE position of the 4-in-1 cutting block before making the chamfers and anterior cut. So we have the guide in place. We'll begin by making our posterior resections. And you can see that we'll pin it to secure it, to reduce toggle. And remember, our posterior, medial, and lateral resection, since there's no cartilage missing, should be 7 millimeters. When we measure on the medial side, it's 6.5, so we're a ½ millimeter short. We measure on the lateral side, it's 7 millimeters. We're hit our target correctly. So we would like to go in and recut the posterior medial resection to gain that extra ½ millimeter of bone resection because the saw skived during the cutting. So we'll go back to our verification worksheet. We'll expand the posterior medial femoral resection subsection of the sheet. Remember, the medial condyle in a varus knee at 90 degrees is relatively unworn from cartilage. Our initial resection was 6.5. The section says the target is 7. We had to recut another ½ millimeter, and so we hit our target of 7 millimeters. Our lateral condyle was unworn, so once again, we had to, we did our measurement of 7, which was correct. So we did not have to do a recut, and our final thickness was 7. And so now the femoral component has now restored the patient's distal and posterior prearthritic joint lines, and by definition, the femoral component is kinematically aligned. We've co-aligned the axes of the component to those of the knee, and we have restored the native resting lengths of the healthy ligaments as long as we restore the tibial joint line as well, which is the next step. So these are the verification checks and caliper measurements we do to set up the tibia. Now, the tibial resection, we like to break it down into 4 steps. We apply an extramedullary tibial guide that's standard in most instrumentation systems. Remember, in kinematic alignment, we do not place the tibial resection in varus or valgus because our target is the patient's prearthritic joint line. If you put your mechanical alignment hat on, you're going to say that most of the time we cut the tibia in varus, but we really don't. Mechanical alignment surgeons cut the tibia in valgus with respect to the patient's prearthritic joint line. So to make the correct resection, we are going to slide at the ankle to set the tibial cut parallel to the prearthritic joint line. We're going to move it 15 millimeters lateral from the ankle, which is a good starting point. Now we'll set the finger and set proximal distal for a conservative resection. We'll place the angel wing through the medial slot. We'll slide the alignment guide at the ankle until the angel wing is parallel to the prearthritic slope, and we pin our guide. We look at this as an educated provisional first cut, understanding that we may want to correct the cut with a degree or 2 of varus or valgus or slope if necessary. We use the resection of the tibia to balance the knee rather than going back and recutting the femur or cutting a healthy ligament, including the PCL. So we'll now go ahead and examine, just like we did with the femoral resections. We don't need an X-ray to do this operation because we're basing it off the joint surfaces that we're looking at. So our double check, once again, is to measure the bone resections and inspect the medial slope. So when we look at the medial slope, it looks like it's a little thicker anterior than posterior, and maybe we might have to increase the slope a degree or 2. The medial resection was 8 and the lateral one was 7. So if anything, we might be a little tight on the lateral side, if at all. But this is a pretty good cut and one that usually gets us in the right spot to begin with. So we, once again, will follow our verification sheet. This is the tibial resection subsection of the sheet that will blow up. And on the medial side, we'll record an 8, and the lateral side will record a 7. And so I'm either thinking in my mind that I should have a nice rectangular extension space, but if I don't, I'm going to be a little tight on the lateral side. And if a resection correction is needed, I will cut about another degree of valgus. That is all on the tibia. So let's look at the decision tree. And this is what really simplifies the operation from the perspective of the surgeon, is that to balance the knee is done by adjusting the position of the tibial component, proximal distal, varus valgus, and slope. That's it. No ligament releases and no recuts of the femur. And when you follow the decision tree and the verification checks, you by default restore the prearthritic tibial compartment forces. We have several papers that reference that in the literature. You restore the resting ligament lengths and the laxities of the native knee. So let's look at the verification checks that we begin with use of the spacer block. So we're going to do verification checks twice to double check our work. First with the First with a spacer block, which will tell us how to fine-tune the varus valgus of the tibial resection. So we have to be armed with an understanding of what the native laxity is in full extension. We have several papers we reference here in JBJS and Journal of Orthopedic Research, where in everybody that you do, unless they have a severe traumatic ligament disruption, multiple ligament injured knee, they have a tight rectangular extension space, without exception. So what's our target with Caliper kinematic alignment is we want a tight rectangular extension space with equal medial and lateral gaps like the native knee. So we verify that by putting a spacer block in full extension. And if you looked there, there was just very subtle opening medial compared to lateral, suggesting that we might need a 1 millimeter valgus recut to get a rectangular extension space. This is exceedingly accurate for restoring the patient's prearthritic joint line and limb alignment. Now, we then consult our decision tree when we have an issue like this. We think we're a little, actually in this case, not tight medial and loose lateral, but we think we're actually a little tight lateral and loose medial in extension. So what are our steps? We're going to go back and make sure that we have removed our osteophytes. Assuming that we did and we're still a little tight lateral to medial, then we're going to recut another millimeter or so of bone off the lateral tibia and insert a millimeter thicker insert, which tightens the medial space, and the resection of bone, 1 millimeter lateral, allows us to get a thicker insert in medially, and we have achieved our goal. So these are just some little surgical techniques with some inexpensive instrumentation to change the varus valgus cut. So this is a recut guide for the right knee in varus that can take an additional 2 degrees off immediately as an example. And if you want to take off just a millimeter, then you can use an angel wing underneath the guide to lift it up. So in this situation, we actually need a little more bone off the lateral side, but I just happen to use this example from another knee showing the guide. Now that we have then balanced our knee in extension by doing our recut when necessary and getting a rectangular extension space, then we're going to insert our trial components for another series of verifications. The first one is to make sure the knee hyperextends passively, like the prearthritic knee. We don't like flexion contractures. We'd like to restore the extension 2, 3, 4 degrees of hyperextension, which has been my experience as necessary when I do ACL reconstruction, which was my first foray into orthopedics. The thing I really enjoyed for about 12 years was ACL reconstruction before transitioning to total knee. And here you can see the knee easily extends with no ricochet, just a nice firm extension with no plasticity And this is a sign that the insert thickness is correct in extension. And then we have to look in the extension space to verify with our eyes. And we do that by making sure that we can see the interface between the femoral component trial, the insert, and the base plate. And there should be negligible VV laxity and full extension. If one side is opening and not the other, then you're going to have to do a recut on the tight side. If both sides are opening a little bit, then get a thicker insert by 1 millimeter and recheck. Now we have to look to see if we restore the normal trapezoidal flexion space of the knee. And we know there's a bit of variability between the patients we do. You that do arthroscopy and do medial and lateral meniscectomies know clearly that the medial compartment is always tighter than the lateral compartment. And between knees, one patient might have a tighter medial compartment than the other, which makes the meniscectomy a little bit more difficult in some knees than others. Therefore, there is no single laxity in the flexion space to shoot for. You want to restore that of the patient's prearthritic laxity to give you a more normal or forgotten joint score of the knee. So we know the medial side is tighter than the lateral side, so we flex the knee. As a rule, the lateral side should open 2, 3, maybe 4 millimeters, but not 1 or 2 and not 5 or 6. And then what we do is we go into flexion. And preoperatively, you can see there's about 15 degrees of internal external rotation, but most of it is internal. And we want to see the same thing, a medial pivot when the joint's compressed, about the same degree when the knee is in 90 degrees of flexion. A second check that you can do when you have a low conforming medial compartment is to measure the AP offset at exposure. So here you can see we just exposed the knee. We've measured the distance. It's 16 millimeters. Remember, we were missing 2 millimeters of cartilage because it was a varus deformity. And now we have a total thickness of 14 millimeters. If the tibia with trial components is more anterior or posterior than that by 1 millimeter or 2, then it's either too tight if it's anterior and too loose if it's posterior. So now we have our trial components in and we're checking. And sure enough, we have a 14 millimeter, which matches the knee at exposure, which means that we have balanced the knee throughout the motion arc and restored the patient's prearthritic medial and lateral tibial compartment forces. This is an example if you have to increase the slope. Once again, if I found that the tibia was not 14 millimeters anterior, but 18, and I had nice stability and extension, which meant that I didn't have too thick of an insert and extension, then I would have to increase my slope. But before doing so, I'm going to go back and look at the piece. And indeed, we thought we might have to take an extra degree or 2, and you can use a guide or just simply draw a little line and just shape and take another millimeter or 2 off the posterior tibia. This will move the tibia posteriorly about 3 to 4 millimeters when you need to do it. Now, our final topic in the presentation is the forgotten joint score, which I thought, as the organizers of this symposium, picked this score because it is the most important and sensitive one for detecting whether or not our total knee arthroplasty techniques are improving. And let me show you some evidence that when you do a calipered kinematically aligned total knee arthroplasty, the forgotten joint score is better than after a mechanically aligned TKA, and it's like a total hip arthroplasty, especially when you use a medial ball and socket knee with a flat lateral insert that allows the full unrestricted internal rotation with flexion. So this is a paper that we published in 2019 entitled Outcomes in Patients with a Calipered Kinematically Aligned TKA that already had a contralateral mechanically aligned TKA. The methods and materials were quite simple. We searched our database from 2013 to 2017 and identified 87 patients with a calipered KA TKA and a prior MA TKA in the opposite limb. 78 patients completed evaluations consisting of 2 anchor questions, 1 which total knee arthroplasty, the mechanical or kinematically aligned TKA, recovered faster? Which one do you like better? And 2 patient-reported outcome measures, the Fogortten Joint Score and the Oxford Knee Score. And the findings are quite interesting. In terms of patient responses, which TKA got better quicker? The KA TKA had a faster recovery 74% of the time. The MA, only 6% of the time. And no difference between the 2 knees in 70% of the patients. And that sort of makes sense because you all know when you do mechanically aligned TKA, you have some great results. But my hypothesis is when you have a great result with mechanically aligned TKA, you've actually restored the patient's kinematic alignment rather than a mechanical alignment. In other words, by default, the bone cuts you made striving for a mechanical alignment led to distal and posterior femoral and tibial resections that match those of the implant. Let's look at which knee do you prefer. So a little over half the time, they prefer the kinematically aligned TKA, and only 8% prefer the MA TKA. And once again, no difference in about 36%. So if you're going to say to a patient, you have a mechanically aligned TKA already, and if you do a kinematically aligned TKA, that 74% of the patients or 4% of the time, you're going to have a faster recovery than you had with your mechanically aligned TKA, and 56% of the time, you're going to like it better. The median patient-reported responses for the Fogortten Joint Score for the Caliper kinematically aligned TKA is 75, whereas in the mechanically aligned TKA, it was only 60. Now remember, the kinematically aligned TKA had a shorter term of follow-up. If you look at the Oxford Knee Score, the scores were actually essentially the same. And this emphasizes, once again, the wisdom of the organizing committee for this symposium selecting the Fogortten Joint Score as the most important score we currently have for assessing our results after total knee arthroplasty. And that's because the Oxford Knee Score has a ceiling effect. It's a terrific score for understanding how much a patient suffers before the operation. But because our arthroplasty results are getting better, there are too many patients with the maximum possible score when you do your follow-up exam, and this leads to the ceiling effect and inability to detect a difference. So here, a 15-point higher Fogortten Joint Score when you do Caliper kinematic alignment rather than mechanical alignment in the same patient. Now, this is my own work. Let's compare this to a randomized trial published entitled A Single Surgeon Series, comparing the outcomes of a cruciate retaining and medially stabilized total knee arthroplasty using kinematic alignment principles. So this is a little bit different because we're going to use kinematic alignment, but we're going to randomize. Patients are going to get a medial ball and socket implant versus what I call a shallow or low conforming implant, which would be consistent with the Vanguard knee, which was used here, Vanguard CR, the Triathlon, the Persona, the Next Gen, DePuy, Attune. They're all shallow, especially on the medial side, that don't provide AP stability. So 53 patients received the medial stabilized design, and 50 patients received the shallow medial and lateral CR insert. Adequately powered study. Both knees, or both implants, were implanted with kinematic alignment principles. At 1 year, there was an 80-point Fogortten Joint Score, even higher than mine, which had a low conforming insert. The study that I just showed you with a 75 score had a low conforming Persona insert, medial and lateral. In this one with a ball and socket, there was an 80-point Fogortten Joint Score for the MS design versus a lower score for the shallow one, a 16-point difference, and this high score was comparable to total hip arthroplasty. So to summarize, when you do kinematic alignment, I think it's important that you use the caliper. So if you like to use the robot, use robot calipered kinematic alignment. If you're going to use navigation calipered kinematic alignment. If you're going to use patient-specific instrumentation. Use Caliper PSI instrumentation. So you check the bone resections after you make them and verify whether or not you achieved your target of restoring the patient's joint lines within a 0.5 millimeter by comparing the resection thickness, adjusting for the curve of the blade and for the cartilage loss, and confirming that it's the same thickness as the condyles of your femoral component. So caliper measurements and follow a series of verification checks, and this will make you a better surgeon. And these values, I believe, should be part of your operative note, and they are much more important than an X-ray at the end of the case, which is a day late, as we say, and $1 short. You need to make sure that you assemble the knee like a very skilled auto company assembles the car. They don't turn it on at the end or take a picture of it to see if the car works. They know the car is going to work because of the series of verification checks they used during the manufacturing process. We also want to use these caliper measurements and verification checks with, remember, the spacer block and trial components to restore the patient's prearthritic tibial joint lines. And when you follow these rules and this surgical technique with manual instruments, the robot, navigation, or PSI, you will achieve a forgotten joint score that should be comparable and perhaps even better at times than your total hip arthroplasty, especially when you use a medial ball and socket implant that provides HB stability and retain your PCL to promote internal rotation, which is maximized when the lateral insert is flat. Those interested in calipered kinematic alignment TKA, may I suggest you visit my website. I'm in Sacramento, California, and operate in Lodi, California. And on that website, if you look at it, it's drstevehowell.com. You can go through a series of educational pieces, including all the publications that we have that you may download for free in PDF format, as well as videos and other interesting topics. So I'd like to thank once again the organizing committee for allowing me to be part of this presentation today, this symposium on a timely topic, calipered kinematic alignment, dear to my heart, and one that I have performed without exception since January of 2006 in nearly 6,000 primary total knee replacements. So thank you very much.
Thank you, Dr. Howell. So next, we're going to invite our famous Professor Yan Chunhui. He is one of the pioneers using KA in Asia area, and he's also doing the KA with some new technique, some new doing the KA with navigation and the robot. So let's welcome Professor Yan Chunhui to introduce KA in the future. Welcome, Professor Yan.
Thank you very much, Professor Chen. Thank you for your kind words. It's my pleasure to join the seminar today. So I'm going to talk about the role of the robotic-assisted surgery in kinematic-aligned total knee arthroplasty. So we know that everybody is different. People have different lower limb alignment. We heard it from Professor Wen just now. The Asian people, we tend to have more constitutional varus compared to the Caucasian patients. So the lower limb alignment may vary a lot. This is our own studies. We actually studied the Chinese knee anatomy very extensively. We found the lower limb alignment was about in average about 2 degrees of varus in Chinese. The joint line obliquity was about 5 degrees instead of 3 degrees compared to the Caucasian. We found more tibial posterior slope in Chinese patients. And we found the relationship between the transepicondylar axis and the posterior condylar line is actually 5 degrees of external rotation instead of 3 degrees in Caucasian patients. And finally, we also found there is more significant anterior femoral bowing in Chinese subjects. All these may contribute to different anatomy and different knee kinematics. So we know the conventional mechanically aligned total knee replacement, we aim for a 0 degrees of lower limb alignment to reduce the risk of aseptic loosening. But most of the prostheses we use are not physiologic because they cannot reproduce the new anatomy. And maybe in the past, the material was not durable enough. For example, the polyethylene insert, it was not cross-linked. There was no antioxidant in it. And we also know that 20% of these patients were not satisfied after a knee replacement. There are maybe various reasons because we try to fit a standard anatomy into patients with their unique own anatomy. Then the surgical plan was not individualized. And if you chase after a neutral mechanical alignment, many a time you need to do excessive medial side release. So that would increase the post-op pain. The patient may have tightness over the medial side, and they may have slower rehabilitation. So we just heard from Dr. Hao, his Caliper technique. So I'm sure you can learn more in his website and watch his videos and Vumadi and a lot of sites. So I also learned this technique from Dr. Hao. I visited his hospital in 2007, so that was about 4 years ago. So after I came back to Hong Kong, I started to doing some kinematic aligned total knee replacement. So I did a single surgeon series. So I did all these operations. I did total knee in 50 patients. 18 of them received a mechanical alignment TKA, and then 32 of them had a KA-TKA. So I used a similar prosthesis like Dr. Hao did. So it's a medial pivot total knee arthroplasty prosthesis. The medial side is a ball and socket joint largely, and on the lateral side, it's more like round and flat. So in the MA-TKA, I used the Cruciate sacrificing design. On the KA-TKA patients, I used the Cruciate retaining design. So this is a typical X-ray before and after KA-TKA patients. You can see that the lower limb alignment, I didn't chase after a neutral alignment. If the patient had a constitutional varus, then I leave it like that. And on the pre-op and post-op X-ray, I measured the lower limb alignment and also the medial, the lateral, the distal femoral angle and the medial proximal tibial angle, and also the tibial slope on the posterior post-op X-ray. So a bit of summary of these results. So all patients completed 6 months of follow-up. There's no significant differences in the pre-op demographics. The mean age of these patients was about 72, a bit old. The mean surgical time for the KA-TKA is about 52 minutes. You can see on the diagram, actually, the learning curve is about 5 cases. After the first 5 cases, I can achieve more or less equal time compared to my MA-TKA. So the learning curve is not very steep. It's about 5 cases. And there was no complication in all these Caliper technique manual KA-TKA. So you can see the post-op X-ray. I measure the accuracy of restoring the natural anatomy. So about the medial proximal tibial angle, you can see there's no difference between the pre-op value and the post-op value. And also the mechanical lateral distal femoral angle, there was no difference essentially between the pre-op and the post-op. That means actually using the Caliper technique, I can relatively accurately restore the normal joint anatomy. But I think there's still some problem in recreating the tibial posterior slope because the pre-op is about 10 degrees and the post-op, I didn't perform a sloped tibial cut. So it's about 7 degrees, and there's a difference between the pre-op and post-op value. In terms of alignment, of course, we can understand because the patient had degeneration, osteoarthritis, so the pre-op varus is a bit more, but post-operatively, I didn't chase after a neutral alignment. So it's still about 3 or 4 degrees of varus remained. So it's quite good. And I also assessed the patient's post-op outcome in terms of the range of motion, the knee society score, and the knee society functional score. But at 6 weeks, 3 months, and 6 months post-op, but there was no difference can be found between the MA group and the KA group. Again, I used another score, hopefully that without much ceiling effect. This is the knee injury and osteoarthritis outcome score, the KOOS score. It's more comprehensive, but also I didn't find any significant difference between the MA and KA group at different time points. Finally, I also used the Fogortten joint score. You can see the result at 6 weeks. 3 months and post-op 6 months. The MA group, the average value is higher than the the KA group is the value is higher than MA group, but that value didn't reach statistical significance. But there's also no difference. So in terms of the Fogortten joint score. So according to this very simple study, I think the technically the Caliper technique for doing the KA TKA is not very difficult. The learning curve is relatively short. It's about 5 cases. The early clinical outcomes, unfortunately, I didn't find any difference compared to my MA-TKA. So initially, I wonder if this is because of the implant choice. We know the AP offset measurement is very important. Dr. Howell also emphasized on this. You have to measure the AP tibial femoral offset before and after the surgery to make sure that they are equal. But with the medial pivot design, the medial side is very constrained. The conformity between the poly and the femoral condyle is very high. So essentially, you cannot measure the AP offset because the contact between the femoral component and the tibial component is fixed. So that could contribute to the inaccuracy of the soft tissue balance. And also, I didn't resurface the patella, and maybe my patients are too old. So there may be various reasons. Then I couldn't find any difference between my KA and MA patients. So where should we go from here? We also know that there are more different concepts or more alignment options in addition to the MA and KA. And we also have the restricted KA, and where we probably do not want to create more than 3 degrees of varus on the tibial side, and on the femoral side, maybe a few degrees of varus and valgus according to the ligament balance. We also have adjusted mechanical alignment, where you don't want to put any varus and valgus on the tibial side, but you can adjust the varus valgus on the femoral side. So there are different alignment targets we can chase after, in addition to the conventional alignments. So another concept a lot of people are talking about now are the functional alignment. So it's similar to the KA or restricted KA, RKA. So we now can make use of the computer navigation and robotic assisted technique. So we can fine tune the resection thickness and plan the bone cut according to the gaps. And the limb alignment can also be assessed intraoperatively because we have the navigation. And that would give additional precision. Because now we know that the non-neutral limb alignment targets can be achieved very reproducibly, and we can also reduce the risk of missing the targets and produce significant alignment outliers. So for the functional alignment, we can see that in the coronal, we can, on the coronal side, the tibial side, we can give about a few degrees of varus. On the sagittal value, we can flex the femur component a little bit. On the axial side, we can rotate the femoral component according to the flexion gap, and we don't have to chase after a neutral alignment. So it's more like a measured resection combined with a gap balancing technique. So this is the robot we've been using since 2009, the Mako from Stryker. I think it has 2 main advantages. One is the enhanced planning. The other one is the dynamic balancing that can help us achieve better results using the functional alignment. So for the dynamic balancing, we can either do a pre-resection balancing. So in that technique, remove all the osteophytes. After that, we tense up the medial collateral ligament in extension and flexion, and we can adjust the bone cut and plus minus the soft tissue release according to our belief. And then after all these cuts were planned on the computer and we're satisfied with the gaps, then we can do the bone cuts. And then after the bone cuts, we check the gaps again. Another technique we can do is a mid-resection balancing. So again, we remove the osteophytes, and then we cut the bone according to the pre-op plans. After you cut the bone, then we check the extension gap. If we found it to be too tight to lax, then we can recut plus minus the soft tissue release. And then we do the flexion gap according to the gap balancing technique. So what we are doing right now is the pre-resection balancing, because we know what the gaps will be before we cut the bone. So that would make the surgery more accurate and minimize the risks or complications. So for the dynamic balancing and extension, first of all, we remove all the osteophytes and then put a knee into extension. So for a varus knee, which is very common in Asian patients, the MCL should be tensed up by putting the medial spacer pedal. So it's like a spoon, you put it in to tense up the MCL, or we can apply the valgus stress on the lateral side. And then we should note on the computer to look at the limb alignment and then to look at if there's any residual flexion contracture, and also pay attention to the medial and lateral gaps, the tightness on both sides. So typically on this X-ray, this picture, you can see after the osteophyte removal, the limb alignment is about 3 degrees of varus, which is not bad, but the knee has a significant flexion contracture. It's about 9 degrees. And looking at the medial side, the gap is about 90 millimeter. On the lateral side, the gap is about 21 millimeter. So the lateral side is slightly loose compared to the medial side. Okay. Then remember, in the functional alignment, we do not have to chase a neutral alignment. We just need it to be acceptable. So anything less than 5 degrees, I think, is acceptable. So we accept less than 5 degrees of varus. If the residual varus is more than 5 degrees, then probably we need to do a little bit of the release. So usually we do a pie crusting of the MCL. If the patient has a valgus knee, then we can accept less than 2 degrees of residual valgus after a knee replacement. And usually we need to release the posterolateral capsule. If the valgus is more severe, then we probably need to release the iliotibial band as well. For patients with significant flexion contracture, my routine is to remove the posterior osteophytes and do some posterior capsular release. So we can either do the capsular release over the tibial side or the femoral side, depending on your preference. For patients less than 10 degrees flexion contracture, usually may want to add 1 millimeter of distal femoral cut. So that would improve at least 5 degrees of flexion contracture. For patients with very severe flexion contracture, more than 10 degrees, probably want to release more extra release of the soft tissue, or you want to cut more distal femur if needed. So this is a patient with a very severe flexion contracture. You can see from the video, we did a provisional posterior femoral condyle cut to get access to the posterior side of the femur. So after we get there, you can remove this piece of osteophyte. Okay, you remove that chunk of osteophyte, that will open up the medial soft tissue. So if the patient, you see a large posterior osteophytes on the pre-op X-ray, you can do a provisional posterior femoral cut. But you have to beware of the balance in the future, because the PCL, the reference line is changed after the provisional posterior femoral condyle cut. So on the extension to continue, then we should assess the medial and lateral gaps in about 10 degrees of flexion, because we eliminate the effect of the posterior tightness of the capsule. So always access the medial and lateral gaps with a little bit of flexion. For the varus knee, in extension, usually the medial gap is tighter than the lateral side. So we can put the tibia in a slight varus cut. And also we can rotate the femur either internally or externally to make sure that the tracking of the tibia and femur would match each other. And for the femoral cut, we can also add 1 or 2 degrees of varus, and that we can match the lateral gap and the medial gap, and cut the both tibia and femur. And for the anchoring, we can, because the computer allows us to anchor the point over the medial side, over the lateral side, or middle side. So that depends on the thickness of the poly you use, and also the degrees of flexion contracture you have. So again, back to this case, the residual limb alignment is 3 degrees. We can accept that. The flexion we want to have is actually 0 degrees. That means there's no flexion contracture. The patient can fully extend the knee. And so we can accept the varus alignment, and we want to balance the medial and lateral gaps by changing or adjusting the bone cuts. So we want to achieve a full extension. Now with the pre-op plan is about 9 degrees. The poly thickness is about 9 millimeters. And we can actually anchor over the medial side and change the lateral side adjustment. So we can either anchor on the medial side and tighten up the lateral side by giving more varus on the tibial component, or we can also anchor on the lateral side and change the position of the medial side. So open up the medial side. So it depends on the preference. In this patient, because of the limb is has a 9 degrees of flexion contracture, so I think it's better to anchor on the lateral side and increase the bone cut on the medial side. In that, we can achieve 2 goals just by moving that. So we can balance the medial lateral side and also eliminate the flexion contracture. So it depends on the intraoperatively, how do you feel? So again, after you achieve good balance in extension, then we will do the flexion gap. So remove the osteophytes and then put the knee in 90 degrees of flexion. So for the varus knee, the medial side should be tensed up either using a puddle, just like this. You can see we'll put in spacer over the medial compartment. And also you can apply a varus, the valgus stress on the lateral side. And then we know that the medial and lateral gaps, the width is represented by the component thickness. And theoretically, we don't have to chase after a rectangular gap because Dr. Hao already told us the lateral side of the knee is more lax than the medial side, especially in flexion. So you don't have to chase an absolute rectangular flexion gap. So you can see in this knee, after we put the knee in about 90 degrees of flexion, the lateral side is more lax, it's about 15 millimeter, and the medial side is about 30 millimeter. Both values are smaller compared to the extension gap. That means the flexion gap now is quite tight compared to our extension gap. So we need to do something to match our flexion gap to the extension gap. So how can we do that? So first of all, if the flexion gap is not too tight, then you can anteriorize the femur. For example, if the flexion gap is only tighter about 1 to 2 millimeters, you can anteriorize or shift the femoral component more anteriorly to compensate for that. But if the flexion gap is tighter by 3 to 4 millimeters, then I think it's very important you should downsize the femur and plus minus anteriorize the femur. So you cut more posterior condylar bone and you can match the flexion gap to the extension gap. Another way to equalize the flexion extension gap is to increase the posterior tibial slope by 1 to 2 degrees. In that way, that would only affect the flexion gap without affecting the extension gap. Right, so the flexion gap imbalance is a not normal phenomenon. We know the medial side is slightly tighter than the lateral side in flexion. If the tightness is, the discrepancy is too big, then you can consider external rotated femur a little bit. You can either anchor over the medial side to tighten up the lateral side, or you can anchor at the lateral side to open up the medial side, depending on your preference, depending on the thickness of the poly you want to use, and also width of the flexion gap. So in this sense, we can see that the flexion gap is much tighter, and the bone resection of the lateral posterior condyle is about 5 millimeters, and the external rotation of the component in the pre-op plan is about 4 degrees, according to the PCL. So we can increase the flexion gap by increase more external rotation. So from 4 degrees, increase about 2 or 3 degrees more. Now here is about 7 degrees. Increase the external rotation, and will also anteriorize the femur a little bit. So you can see that after the fine adjustment, the flexion gap is about 18 millimeters, both on the medial side and lateral side. So that's about equal. So you can see that now we have a balanced flexion gap, also a balanced extension gap, except that the extension gap is wider than the flexion gap. People may ask why. It's because the knee has about 9 degrees of flexion contracture. So the extension gap, if we leave it a bit loose, then we can correct the flexion contracture after the surgery. Right, so we can also potentially increase the tibial slope a little bit, because now it's only about 3 degrees. In CR knee, people would say they recommend 5 degrees of posterior slope. So we can increase the posterior slope a little bit to widen up the flexion gap. So when we do the dynamic balancing in flexion, we have to be aware of the bone defects. For example, in the valgus knee, we have to pay attention to the hypoplasia of the lateral posterior condyle. In varus knee, we may need to do a provisional cut to remove the large posterior femoral osteophyte. And we may need to use the stacks to stack up the spacer puddles. And we'll also need to be aware of the flexion laxity, especially if you use a PS knee, because that would removing the posterior cruciate ligament that will open up the flexion gap even more. And in patients with very severe valgus and varus knee, the collateral ligaments may be lax or stretched out, and we may need to use spacer paddles both over the medial side and lateral side to balance the knee. So I'll show you one example. This patient has bilateral varus OA knee. The left side is more severe compared to the right side. So we did the right side, it's less varus, there's a less flexion contracture, but the patient has a limited flexion. So you can see that initial alignment after the registration, before any release, the lower limb is about in 14 degrees of varus. The flexion contracture is about 3 degrees. It was not too bad. So after we remove the osteophytes, you can see the lower limb alignment can be corrected to 5 degrees of varus, which is quite good. And the residual flexion contracture is about 2 degrees. And you can see the gaps, the medial side and lateral side. The medial side is about 18 millimeter and the lateral side is about 22. So the medial side is a bit tighter. And the residual, we put the femoral component in slightly more valgus. So the remove more bone of the lateral side. So we adjust the component positions. So initially, according to the pre-op plan, the femoral component was in slight valgus. We changed it to 1 degree of varus. After that, you can see that we balance out the medial side and lateral side. Now the extension gap is 19-19 on both sides, and the bone resection of the lateral side, femoral condyle, is reduced. And that will give us about 4 degrees of residual varus and 1 degree of flexion contracture, which is negligible. And then we check the flexion gap. You can see the flexion gap is about 15-15 on medial and lateral side. So it's a bit tight compared to the extension gap because we want 18 to 19 millimeters of gaps because the combined component thickness and the poly is about 19 millimeters. So we noted on the pre-op plan, the femoral component size is 4. So in this sense, the difference between the flexion gap and the extension gap is about 4 millimeters. So we want to downsize the femoral component. So we changed that. We changed the femoral component to size 3. So we downsize it, and then we resect more bone from the posterior side. You can see that after we changed the femoral component, already the flexion gap has opened up compared to the previous slide. So we downsize and also anteriorize the femur a little bit. And then we changed the posterior slope of the tibials from 3 degrees to 4 degrees. Now you can see that after that, we can achieve very beautiful numbers on the extension gap and the flexion gap. Okay, then we can bring in the robot and cut the bone. So after the bone cut, we put in the trowels and the prosthesis and check the flexion extension gap again. That reproduces the pre-op value. So again, balanced out in the flexion gap and the extension gap. It's quite good. So on the left side, because the patient has more varus and more flexion contracture, but the patient has better flexion before the operation. So you can see the lower limb varus before we do any release is about 18 degrees. So compared to the right side, which was 14 degrees, this is more severe. And the patient has 9 degrees of flexion contracture. So again, we apply the same principles. First of all, after the osteophyte removal, we corrected the residual varus to 6 degrees, but the patient also still has 10 degrees of flexion contracture. Then we did pie crusting of the MCL and corrected the residual varus from 6 degrees to 4 degrees. So now it's within acceptable range. So anything less than 5 degrees varus we can accept. But you can see the extension gap, the medial side is still very tight, tighter compared to the lateral side. Right, and residual flexion contracture is about 12 degrees, which we need to improve. So we put the femoral component in 1 degree of varus. That would open up the medial side. We anchor on the lateral side. So we did not change any bone cut of the lateral distal femoral condyle. We increased the bone cut of the medial distal femoral condyle. So after we change the position, now we can achieve the extension gap to 20 and 21 millimeter on both sides. And then on the flexion gap, because the flexion gap is a bit too tight, we also try to downsize the femoral component from 4 to size 3. and also anteriorize the femoral component as well as increase the posterior tibial slope. So with a combined method, then we can open up the flexing gap a little bit more. And we can also external rotate the femoral component to fine tune the medial side and lateral side in the flexion. So after that, we can bring the robot and do the bone cut. So this is when we put in the trials and the prosthesis, you can see that after we put in the trials and prosthesis, the residual limb varus is about 4 degrees, which is acceptable. The limb is now in 1 degree of hyperextension. I think this is totally acceptable. So we eliminated the flexing contracture. And the flexing gap is also quite good. It's about 90 and 20 on the medial and lateral side. So these are the post-op x-rays. You can see the implants put in a very nice position, AP and lateral. We used a cementless total knee combined with a robotic technique because we believe that there's evidence showing cementless total knee now has better long-term survival compared to the cementless cemented prosthesis. So for the dynamic balancing, remember the things, the steps we proposed. Pay attention to dynamic balancing. If the posterior cruciate ligament is too tight, you want to lift off. There may be a lift off in a flexion, and what you want to do is to increase the tibial slope to open up the flexion gap. Okay, and if there's a flexion contracture, you want to cut more bone from the distal femur, and in that sense, you can open up the extension gap without affecting the flexion gap. And pay attention to the varus valgus cut over the tibial side because that would affect both the flexion gap and extension gap. So do not put too much varus and valgus over the tibial side. And beware when you attempt to change the femoral rotation because if you change it, then if you cut already and you want to recut, then you may create some bone defects over the uncut side. So it's better to have the pre-resection balance done before you cut the bone. If you cut a bone already and then try to recut, then you may create some problems. So I think with the dynamic balancing and robotic assisted surgery, now we can achieve balanced gaps more accurately, and also we can have more functional acceptable alignments. And of course, the advantages of robotic arm-assisted total knee replacement has been reported in the literature. This is a paper published by Faris Haddad. They look at 40 conventional total knee versus 40 robotic arm-assisted total knee, and they found the patient had a reduced post-op pain. There's decreased analgesia requirement, decreased post-op drop of the hemoglobin, and also shorter time to straight leg raise and faster rehabilitation. The paper from Michael Mond, they also showed that the 3D planning is very accurate. So in the Mako total knee, they also used the CR implant. All patients can achieve a balanced extension gap, and 99% of the patients can achieve a balanced flexing gap. So, and also the pre-op CT plan predict within 1 implant size of the actual tibial and femoral implants in 99% and 98% of the patients respectively. So the accuracy of the robotic surgery is very good. And finally, the paper from William Hozak showed that there's improved component placement accuracy with the Mako total knee. So they studied 143 robotic total knee compared to 86 conventional total knee, and there was absolute deviation of the surgical plan was assessed, and they showed that the robotic arm total knee demonstrated significantly greater accuracy in terms of the tibial component alignment, the femoral component rotation, and also the tibial slope. So in summary, I think the robotic assisted total knee replacement is a very encouraging tool we can have. It's proved to be accurate and also precise in bone resection. And it also allows surgeon to have more options in the surgical targets. So we do not have to chase after mechanical alignment. We can now do a functional alignment or kinematic alignment. It also gives you the option of dynamic balancing, so we can intraoperatively adjust a bone resection plan compared to the pre-op plan. And finally, we can achieve a functional alignment, KA, more easily than chasing after mechanical alignment. So our future plan for us, we plan to do a randomized control trial using the Mako robot to compare MATKA to KATKA. And hopefully we can do this study this year, and if we have some results, then we can share with you. Thank you very much.
Thank you, Professor Yan. Okay, so to be the host, I raised several questions here, and I think we can, all the guests can raise questions and have discussion about the kinematic alignment. So, Dr. Howell, is there any contraindication, do you think, for KA technique?
Well, that always is an important question, because when you start off with this, like I did in 2006, I was afraid of the more severe deformities. And I think any surgeon that's interested in calipered kinematic alignment should start with simple varus knees. And then as they gain experience and confidence, they'll start to recognize that they won't be cutting ligaments like they used to. And then they'll be confronted by some cases which really are not amenable to mechanical alignment. A femoral shaft fracture that left a deformity, you can have a tibial shaft fracture, and those kind of things, or a deformity like achondroplasia. And how are you going to do mechanical alignment in those knees? You really can't. But you find that when you apply the kinematic alignment principles, they can be used on everyone's knee. And so my own experience, as I mentioned, is over close to 6,000 primary knees. I have performed kinematic alignment in everybody beginning in April of 2006. And we did so without any pre-operative limitations, such as a flexion contracture or a severe varus or valgus deformity. And we also did not restrict the correction, so that in every case, we restored the patient's pre-arthritic distal and posterior femoral joint lines and tibial joint lines and pre-arthritic limb alignment. And I think you need to have a change in hat, if you will. The hat that you put on and will determine how you think about the knee. If you wear the mechanical alignment hat, when you try to do calipered kinematic alignment, you will get confused, because you will be trying to assess your cuts that you're doing with kinematic alignment based on your mechanical alignment experience. My suggestion is, when you do kinematic alignment, you put your kinematic alignment hat on and you go for the kinematic alignment target. So if I do kinematic alignment on a varus knee or varus limb, I am going to restore the patient's pre-arthritic varus and valgus alignment, which is not in varus. However, a mechanical alignment surgeon will be putting that in valgus. So the short answer to this is, once you get your experience, you can do any knee that you want with calipered kinematic alignment and expect a good long-term survivorship, as we've shown with our 10-year study.
Okay, thank you. So when you're doing the KA, do you always restore the tibial slope, or do you fine-tune about the tibial slope?
So when you think about the tibial slope, what impact does it have in the knee? It depends on whether or not you keep the posterior cruciate ligament. Now, I'm a proponent of keeping the posterior cruciate ligament, because when you cut it, your flexion space gets more lax, an unpredictable amount, and you lose the passive internal rotation of the tibia with flexion, which is necessary to reduce the Q angle and for the patella to track properly and reduce the risk of anterior knee pain. Now, so I'm going to discuss what I do with the tibial slope when I keep the cruciate ligament, the posterior cruciate ligament, and you need to restore the native slope. How do I know this? We have an article by Net Appeal where we looked at 2,000 or some knees that we did and found about 8 that had tibial component failure. And in kinematic alignment, we don't see varus tibial component failure. We see posterior failure. And occurs when we don't match the patient's prearthritic slope. So when we put the tibial component in too much slope, the flexion space gets loose and the femur starts to impact on the posterior tibia, which causes it to either subside or the posterior edge to wear and instability. If we put in too little slope, it gets too tight and it forces the tibia anterior as well, and you end up having the same loading mechanism. So if you want to reduce the risk of tibial component failure from either posterior subsidence of the base plate or posterior edge wear of the insert, then I think you need to restore the patient's prearthritic slope in every knee. And that is why the verification check is to look at the piece of bone you resect, because measuring that on a preoperative x-ray is very prone to inaccuracy, and trying to create that in the operating room using a computer or something else can be very challenging. So the best check from our viewpoint, pick up the piece of bone you cut from the tibia, look at the medial side. If you need to, place an osteotome on the articular surface and see if it's pretty parallel or not to the resected surface. And when it's not, make an adjustment to restore the native slope, especially when you keep the PCL when you perform calipered, kinematically aligned total knee arthroplasty.
So as you mentioned just then, so do you think the KA technique was a technique need special prosthesis, like you recommend using CR prosthesis or MP prosthesis other than PS?
Yes, so I've had an extensive experience over these 14, 15 years with a variety of prostheses. And I will say that up until 2017, I thought that KA worked better with these prostheses than MA, but there wasn't much difference between them. So let me share my experience briefly. The first 900 I did was with a Vanguard CR shallow or low conforming medial lateral insert. The second 13 or 1400 were Striker Triathlon Cruciate retaining with a shallow medial lateral insert. Then I did diffuse Sigma 500 CR, once again with shallow insert, and then about 22 or 300 Persona CRs, once again with shallow medial lateral inserts. So with that experience, I thought the implants didn't make a big difference. But then in 2017, I started to use a medial ball and socket insert with a flat lateral surface. And this is designed by Pinskarova and Freeman. It's the Medacta GMK Sphere knee. The Safe knee was the predecessor to it. And my initial experience was I was worried that I was going to get kinematic conflict and an overtense flexion space because of the increased AP stability from the socket. But kinematic alignment enables you to use these implants in an optimal way because you're restoring the native joint surfaces. So by definition, you're aligning the components axes to those of the knee, and you're restoring the resting lengths of your ligaments. And I've been very pleasantly surprised that these patients tend to be a more athletic-like patient, or say they have a more athletic-like knee, because the medial socket reduces the AP motion medially, and the flat lateral insert allows it to internally rotate maximally, which unloads the tension in the anterior portion of the knee as you flex it. And it reduces the risk that the patient comes in and says, "Doctor, my knee is stiff." And you say, "Well, will you please bend your good knee?" And it bends normally. And then you say, "Please bend your other knee, the one you had, the knee replacement that I put in." And it also bends normally. But then she says it's tight. And it usually is around 80, 90, 100 degrees of flexion. That's when it starts. And I believe it's because the tibia is trying to internally rotate the 23 degrees it normally does by 120 degrees. And it can't do so because of the posterior lateral rim on the insert. So to summarize, whatever insert or implant that you're currently using, I think that if you do unrestricted calipered kinematic alignment, you do it without limitation based on preoperative deformity and correct it to the normal patient's anatomy, that you will have a better result with those implants than when you use them with MA. But if you want to move to the next level, if you want to offer an athletic-like knee replacement, then consider the medial ball and socket with a flat lateral insert. And I think as the study by that I referenced from Sydney, Australia showed, the forgotten joint score approaches 80, which is good or better than a total hip arthroplasty.
Okay, thank you. Any question from our guests?
I have a question for Dr. Hao. In patients with very severe flexion contracture, I'm a bit concerned when I use a cruciate retaining prosthesis, because without releasing the PCL, most of the time we cannot correct very severe flexion contracture. So I would like to have your opinion. So if you see a patient with more than 20 degrees of flexion contracture, how can you do a TKA using a CR prosthesis?
Well, initially, when we started doing this back in 2006, we were a little surprised because we were taking so much less bone off the distal femur than we did when we were doing mechanical alignment. And I thought, oh, we're never going to get these knees straight. And what we found is when you have a bad flexion contracture, I think it is important to look at that lateral x-ray and see whether or not there is large osteophytes, not only proximal to the posterior femoral condyle, but also proximal to the posterior tibia. And get your finger in when you're doing your operation in the posterior compartments after you do your distal and posterior femoral resection, tibial resection. You usually have a 15 or 16, 18 millimeter gap to get your curved osteotomes in, make sure those osteophytes are removed. And when the flexion contracture is severe, take a 3/4 inch curved osteotome on either side of the PCL and strip the capsule off the posterior femur. Then with trial components in the knee, if the knee still won't fully extend, then give the knee a little push by pushing posterior on the patella, and you'll find that that little bridge of capsule between the medial lateral compartments and posterior to the PCL will stretch. And you will get a plastic deformation, much like the video that I showed in the knee, the knee will just fall into extension and stay there and not be rubbery. So I think that with experience, you'll find that these flexion contractures are very easily treated, retaining the PCL, and with calipered kinematic alignment, as long as you're careful with the posterior bone resection, release the posterior capsule on either side of the PCL, and remember to do that little push to get it in hyperextension. And I think you'll be successful. You'll probably be surprised, like I've been over these years, at how reliable the technique can be.
How often do you need to recess the PCL if intraoperatively, if you find the patient's flexion gap is a bit tight?
So recession of the PCL or release of the collateral ligaments or the retinacular ligaments, if you're wearing your calipered kinematic alignment hat, are really signs to you that your femoral and tibial components are not restoring the patient's native joint line, or you have too thick of an insert implanted. So if I see the flexion space is tight relative to the extension space, then I would go to my decision tree, which gives me 6 options. And if the flexion space is tight, but you're excellent in extension, then the only real explanation for that is too little posterior slope. So then you pull your tibial bone resection up, you take a look at it from the medial side, you say, you know something, I bet I can add 2 or 3 degrees of slope to get it parallel to the original articular surface. That will then allow the tibia to move posterior relative to the femur with the knee in 90 degrees of flexion. And by and large, that takes care of the problem. So I cannot remember the last time I cut a PCL, maybe 2 or 3 times with really, really chronic ACL deficient knees, you get into trouble where instead of posterior lateral bone wear, you have posterior medial bone wear, and that tibia is sitting way, way back on the femur sitting way, way posterior on the tibia. And in that case, sometimes the PCL can contract. And then I will not be hesitant to actually cut the PCL. And if you're using a medial stabilized knee with a ball and socket, you don't have to change the femur. All you have to do is reduce the slope either by a recut or bone grafting the posterior portion of the tibia to lift the posterior aspect of the base plate proximal and reduce your slope 3 or 4 degrees. and that will tighten your flexion space without much of an effect on your extension space. So that's how I look at the PCL. It should not be needed a recession, and if it is, you usually have your slope wrong or your inserts too thick.
Okay. Any other questions?
Yes, may I have a question also for Professor Howell? And I noticed that your technique is a femur cut first technique, but in some surgeon and the traditional way is use the tibia cut first. Can you explain what's your prefer? If we use the tibia cut first, can we still do the TKA? You know.
Yes, so the question is, can you do the tibia cut first when you're doing kinematic alignment? As you saw with our verification worksheet, it works better when you do the femur first. If you're of the viewpoint that, well, I'd like to cut a little of the tibia out to give me some room to work, you can do that, but you have to be willing to recut the tibia to balance the knee in extension and in flexion. So the problem is when you don't have a good educated first cut on the tibia, it can be hard to correct when you're off varus valgus or slope because you really don't know how much you cut if you do a provisional cut that's not close to the target. Remember that in kinematic alignment, we're restoring the rotational axes of the patient's knee with those of the component. And where do the axes sit? They're in the femur. So the only way to do that is to set the femur correctly first and then adjust the tibia is the most easiest way to do it. And that's why we use the caliper to measure the bone resections distal and posterior and adjust the resection thicknesses to within 0.5 millimeter of target. And by that, we can get the femoral component properly positioned. That is 85% of the operation. The rest is look at the decision tree. There's only 6 options and adjust the proximal distal, slope, or varus valgus of the tibial resection to balance the knee. And it becomes a very easy mental exercise in the operating room. In the old days when I did mechanical alignment, if I did 4 in a day, I said, oh, I wonder which one's not going to like the knee. And I would be tired mentally at the end of the day trying to figure, did I need to release this ligament, or I did, or I shouldn't have, or I should have recut the femur, but I didn't, or maybe I recut the femur and got myself chasing my tail and got really loose. All of that scenario goes away when you do calipered kinematic alignment, femur first, tibia second. And at the end of the day, I can now do 6 by, within 6 hours of starting. And I'm tired physically, but not mentally. And I'm fairly confident because I've measured the bone resections, I've followed the verification checks, that those patients will have a very predictable and relatively easy recovery. And they're going to send their friends for me to do their knee. And they're going to come into the office not very frequently for problems, which shortens my workday and gives me enjoyment when I do the office practice as well as the operating room practice.
Okay.
Any other questions? Okay. Since we have no further questions, it's a pity for me to stop our program right now. As we all know, TKA was one of the most successful surgery in last century, but there are still 20% patients not satisfied. So that's our goal to pursue the Fogortten knee for our patients. So kinematic aligned TKA was a promising technique, but there are still a lot of issues we need to discuss. So today is a good beginning. Hopefully we can work together to improve this technique, to find the real result of the K technique, and to pursue the Fogortten knee for our patients. Thank you, everyone. Thank you for our distinguished guests.
So I just want to thank the society, the Asian Society of Arthroplasty, for one, picking the topic of calipered kinematic alignment. It's a great honor for me to have spent the last 2 hours or so discussing this interesting topic with the leaders of Asia. And I really thought that the title was so appropriate, picking the forgotten joint score as our metric for determining our success or failure of total knee replacement. So once again, it was indeed an honor. And I really feel that the fact that this technique is of interest in Asia and internationally gives me great satisfaction as I go to my later years of practice, that maybe together we can offer the patient a better way to do knee arthroplasty, give them a more predictable and quicker recovery, and give them an enduring prosthesis that can last their lifetime and allow them in their declining years to be as active as their body will permit. And I think our next target is the athlete's knee. And I believe the use of a medial ball and socket with flat insert coupled with kinematic alignment provides the ideal combination for achieving that goal. So once again, thank you very, very much.
Okay.
Okay.
All right.
All right. Thank you.
Okay, sounds good. All right.
Thank you,
Good day.
everyone. Bye-bye.
Bye-bye.
Thank you.